patients in communities on ECQ. Actually, when I was preparing the slides today, I was like, oh, ECQ pa ang term namin. Maybe we should consider changing it to baka GCQ na or what. Um, because I think majority of the Philippines, which is good, is on GCQ. Thanks also for joining despite the bagyo. Medyo rainy, I think in where most of us are, no. So we're happy na at least may internet tayo. We welcome our colleagues from PSHPM. We welcome our speakers, Dr. May Corvera, Dr. June Razon, Dr. Agnes, and I'm sure soon we will have more colleagues from PSHPM. This webinar is also co-sponsored, done in collaboration with PSPHP, so I welcome many of the members and Secretariat, and also Hospice Philippines and the Ruth Foundation. I also see many colleagues from hospitals, from other medical societies, from different parts of the country. We have people in the DOH regional offices as well, and yeah, and other hospitals across the country. So I'm sure it will be an exciting time. And my role is basically just to introduce the topic. So let me move forward. Reminder lang for those who come in, kindly make sure that your microphone is mute. Tapos kindly also rename to show your affiliation para we can also have a better idea who you are. So we're very happy to inform everybody that the partnership of PSHPM, Philippine Society of Hospice and Palliative Medicine, in partnership with Hospice Philippines and also PSPHP and the Reef Foundation, we have come up actually with set of three sets of palliative care guidelines. Number one, part one, which is the focus of today's webinar, is on care for palliative and bedridden patients in communities on ECQ. Actually, basically, this is really for community level and best targeted for LGUs, for MHOs, city health officers, RHUs, and our colleagues also, especially in level 1, level 2 hospitals. The part two of the guidance is on patients facing life-threatening illnesses in hospitals. And this is a guidance specifically designed for level 1 and level 2 hospitals, especially in provinces, in rural communities, where we don't have palliative care specialists. The webinar for part two actually will be on Monday. And yeah, and then the third part, part three, is triage decisions, shared decision making, and advanced care planning for the COVID situation. And it's also designed for level 2 and 3 healthcare facilities. Part three webinar will be on Wednesday next week. So what we're doing now is basically introducing these guidelines for specific audiences. And actually, this is our second webinar, because last April 6th, we had the first trial webinar, which is very much similar to what we're doing now, similar content. And at that time, we also got feedback from community what actually is needed in terms of palliative care. So I think everybody is concerned what really palliative care is, and is it really important for COVID? Even for us doctors, sometimes it's difficult to understand what really it is, no? Pero we also see hear every day about families with people facing end of life circumstances, and in the COVID situation, it's different than usual, and it's also very difficult for families and for patients themselves, because in a few days, the situation can go really bad and the patient can expire. And even more difficult, actually, it is for the families, because you have to face the situation with somebody on the end phases of life, and also, funeral and bereavement processes, which is a bit new in the country because of restrictions in travel. So all of these are actually covered by the guidelines. The first part is mainly for communities, but then the second and the third part of the guidelines are on the specific topics I have described. And after my part, a lot more discussion will be done, and we hope also that there will be sharing of experiences, especially from our colleagues in palliative care. So we're very happy that you can join us. We are Philippine Society of Public Health Physicians, and we're very happy to work with our colleagues in communities, in hospitals, and also in medical societies, so that we can help our colleagues also as they manage cases, and also our families and our patients. There is also an initiative, announcement lang to, and this is my last slide. Uh, we have a hotline, a kind of a hotline that people can use, no, especially for concerns on palliative care. Like you have questions on pain, how to manage symptoms, and so on. So uh, the hotline is available for medical professionals in different provinces to use. So I think this is my last slide actually, and I will be turning over to our colleague, Dr. May Corvera. She will introduce the speakers, and then she will also start the discussions on community palliative care. So thank you very much, and over to you, Dr. May.
Okay.
I
Thank
hope you can flash the slides. Thank you.
Okay. Yes, thank you so much, Dr. Lester, and especially to PSPHP for hosting this alongside us. This collaboration has been an ongoing work for the past almost 2 months, I think. But we are here and we're just happy to see more participants and new participants because this is really the plan to share this work to the community, to the healthcare providers in the community, so we can work together for better patient care, especially during this time of pandemic. So I will share my screen. All right. So, well, like Dr. Lester said, it will be three of us who will be sharing with you this evening. I will first take on the first part, which will deal with the background again of all this and what is our targets, and then I'll go on to the basic care in the home until pain. So I'm Dr. May Corvera again. I'm a member of the Philippine Society of Hospice and Palliative Medicine. I'm also member of the Hospice Philippines Incorporated, and also a member of the Ruth Foundation. So we're just thankful again to have you. And then followed by me will be Dr. June Razon, who is the present president of Hospice Philippines, or the National Hospice and Palliative Care Council of the Philippines. And then to follow and to give our third and last topic under this community guidelines would be Dr. Agnes Bausa, who is the past president of Hospice Philippines and also a board member of the Philippine Society of Hospice and Palliative Medicine. So I'll just proceed with the first part. And just to give again this background, I know Dr. Lester shared, how we started and why all of this is necessary. I just like to highlight here that um, the trigger really for this to be brought out and to be worked on was our present pandemic. And being in the field of care, where in our primary recipients of care are those in the fragile uh, part of our fragile population, so to say. So these are not just elderly, these are patients who are also facing life limiting illness, chronic illness, and this would range from pediatric patients to elderly patients. And these are patients who have ongoing treatment or may be at high risk for infection because of their immunocompromised state. So as we are seeing the number of complicated cases of severe pneumonia, to which our fragile population is very susceptible to, and with the uncertainty of COVID-19, as we are all just learning, how to best manage, we have also recognized that this fragile population has also been in a way not totally forgotten, but the care, their direct care has been lagged. We have lagged behind in their care because of all of the focus going around COVID-19. So we know that, especially with the enhanced community quarantine, they're not able to follow up or even get treatment, focusing perhaps even on our cancer patients. A lot of their treatments, some have been delayed, some have been stuck in hospitals and not been able to go home to their own families for continued support and care. So this is what triggered the making of these guidance documents amidst this pandemic. Now, these are still a work in progress. These are all provisional recommendations, but these really aim to enable our health professionals to make decisions amidst COVID. And we also want to ensure through this guidance that we work together in attending to the continuing needs of our fragile population. Now, these guidance documents, of course, primarily aim to give guidance on quality palliative care. Not only is palliative care new to the majority of our professional healthcare professionals, we have to start with the basic principles behind this care, but at the same time work within standards that can be applied and should be applied to the care from community to hospital level. And we also aim to enable and empower families within the communities. Now, just for an example, I work with a foundation who used to regularly visit patients needing palliative care in their own homes. But because of the quarantine, we have been needing to um, oversee their care and give them care and advice through telephone calls. And we have seen actually over the past 2 months of this, we have seen families really empowered and are able to follow the instructions of our nurses who call them at least once a week, especially if they're in the hospice category. And so we have seen how families are able to take on direct care, and they have become more responsible in attending to the continuing needs of their loved one who is greatly in need of quality of life care. So whether it be in terms of bedside care, managing pain, daily physical care for them, and even preventive care, and even the emotional parts of caring, we're able to empower them even through telephone. So we just need more partners, of course, to continue doing this among for our patients in the community. So this is one of the main purposes also of this guidance document, to empower our partners in the community. Now, for this particular guidance document for the community, we have identified our target users primarily as those working with municipal health offices, our RHU physicians, our public health nurses, and other LGU and RHU staff. But at the same time, other primary community health workers who may be working with NGOs or maybe just private communities that are giving primary health care. Um, now, just to go back to the basics, like I said, we will continue introducing this definition of palliative care, perhaps in every one of our talks that we give, because we need to really get this out and make our partners in care embrace this definition. And this is the World Health definition, which has actually been improved twice, no, and has been strengthened twice. And this is the most recent, and it still remains as applicable now. And it resounds the message really that palliative care is about quality of life care. And it's ensuring that we are able to give quality of life care to our patients who are facing these types of illnesses. And not only does it highlight care for the patients, but also to their families. And it deals primarily with problems associated with, like what I said, life-threatening illnesses. And the approach is not just treating symptoms as they come, but as with primary care, it also deals with preventing those symptoms, preventing suffering. And understanding the cause of those sufferings. So we know as holistic care providers, as physicians, we have to care for the whole person. And we know that suffering is not just physical, but along with any illness, there is emotional and spiritual suffering and even social suffering. So we need to understand these symptoms and where they begin, and also address that. And then we even need to predict these symptoms. So, for example, for patients with advanced cancers, we can predict symptoms that that may arise with progressing illness. So, for example, you would have a patient with lung metastasis, not yet dyspneic, but you know that as the illness progresses, as perhaps the lung mass would progress, you can already forewarn or explain to the patient and their family that these are the symptoms that we need to look out for, and this is what we could do. So it's not just preventing and understanding, it's predicting these symptoms or these causes of suffering. And after prevention, of course, once it's there, we have to know how to relieve these sufferings, these symptoms based on the underlying illness, based on the pathophysiology of the illness. And as we relieve it, we also provide for rehabilitative support, be it physical, nutritional, emotional support, and spiritual support, which continues to work towards maintaining, again, the quality of life of these patients. So that's our definition, and that's something we all want to embrace. We want our colleagues to embrace this definition as they provide palliative care. Now, these are just a table of the common health concerns, that we see in primary palliative care in the community. And we have just divided them into physical care needs and psychological, emotional, and spiritual care needs. So as you can see, palliative care is not just holding the hand of the patient, as some might say. This is just, oh, this is end of life care. It's, just being there, being present. But on the contrary, if you look at these needs, um, primary palliative care needs in this table, you can see that it is a very um, uh, complex group of needs, and it's not possible to be done only by just the doctor. That's why we need to attend to these needs as a team. There should always be, of course, a physician overseeing the assessment and prescription of the physical care needs, at the same time providing recommendation as to the holistic plan of care. So as we go along and as we progress with these guidance documents, we will learn more about how to attend to these physical needs, to each one of these symptoms, especially in our guidance document number 2. But we will go over them um, uh, in this guidance document as in the context of the community. So my colleagues will be sharing more of this. And then also to identify and highlight the psychological, emotional, and spiritual needs. And that is why, again, we work within, ideally, an interdisciplinary team. So we are to look at the resources in the community, who can provide spiritual care, who can be on call, which parish is closest to this patient, which church, or where do they derive their spiritual care. Are the social workers in our community also offering
Mahal.
psychosocial care?
Timpla ka kape.
And also for emotional care, some hospitals or some NGOs may have counselors that can resource for emotional care as well. So these, as you see, are is our um, is our task, to address to all these common primary palliative care needs for one patient and their family. So now we go to care in the home, which is right now, of course, very limited for us who are working in communities. As I said, we are not able to make our usual daily home visits to our patients, but we have been making calls. But for some of the patients who we feel really need to face-to-face care, some of our doctors do volunteer and willingly go, and our nurses in the foundation, they go, but with proper PPEs, of course. But all the more reason that we are to empower the family members of our patients in the care in the home. So the the general reminders here are for us as doctors, as health professionals, to enable the caregivers to effectively provide palliative care in the homes. And these are some of the ways we would approach this, like I said, by empowering families. So we teach them how to take care of the patient and reassure them that they can. I think this is a big, this is something very important to emphasize. To empower them is also to give them that confidence that they can acquire when you give them the amount of knowledge, the step-by-step approach, for example, how to administer a certain medication or how to dress a wound or how to monitor, vital signs. These are actually things that family members can do once they're given, good support and education as to how to go about them. And they themselves will be surprised na kaya pala namin alagaan ng sapat si tatay, because they also know that there's someone who can guide them and that they can go back to. And another important note here is that make sure that there are at least 2 or 3 family members involved in the care of the patient and that you can teach. And especially when, of course, when during this time of social distancing, we have to also be more limiting in the care of the patient, maybe one at a time, unless there's really need to mobilize the patient with 2, but we still need to maintain those precautions. For making sure that COVID exposure to COVID patients are also, we are on the watch for that. So the caregivers, the direct care providers in the home should be very careful in terms of their going in and out of the house and to the patient. So they should maintain those infectious disease precautions, infection control precautions, so that when the risk of letting any contamination of these patients to be avoided. Now, of course, most of us now in the community are well instructed about what to look out for in terms of possible COVID symptoms. So the care providers in the home should again be reviewed and reminded of these, and how to take care to prevent this by their washing of hands and how to regularly sanitize personal items and surfaces, and even to monitor their own symptoms. Now, we still are not, of course, seeing like perhaps like in Italy, where they really had to attend to COVID patients in their own homes because of the number of patients that could not be accommodated already in the hospital. We're not seeing this yet, but for COVID-19 patients that may later on, where we are hoping we don't see that day, but that we have to attend to them in the home because best possible care is still in the hospital as of now. But we, of course, have to still take those precautions about droplet spread, for droplet spread, and also making sure their caretakers have access to personal protective equipment. And so this is part of the education we have to give to both the patient and the care providers in the home. Um, Now, monitoring in the home. So we would usually advise our families to have their own logbook, no, or their own monitoring logbook. And each day, especially now, if the patient does have active symptoms, these should, of course, be reported right away. And at the same time, if the symptoms are not outright, or if uh, they are not sure, there should be regular monitoring. And this is something we need to teach the families how to do. And another very common, of course, thing we see in the home setting, especially in our culture, usually isa lang ang family member talaga na nakatutok, no, sa pasyente. It's either the youngest child or someone who doesn't work, and not knowingly, we may actually encounter na burnout of the immediate care providers of these patients. It's important to have a way to check for that as well. Kinakamusta namin yung nag-aalaga, kamustahin natin, and to check for signs of burnout. Before this pandemic, our team in home care under the foundation would even attend to the care provider sometimes by giving a short therapeutic massage, especially for mothers who are taking care of their pediatric patients. We have, a few pediatric patients with cerebral palsy who we used to visit regularly in their home, and you can see the burnout in their mothers, the ones caring for them. So we have to check for that as well. Now, another very important thing we advise for caring in the home, for caring for patients in the home, is preparing this list of essential contacts from resources or emergency services, perhaps in the barangay, the one from the hospital, who we can call in the ER, or if it's a social problem, or someone needing support financially, we have to direct them to the available services of the DSWD, even numbers of the parish, and even listing down numbers of family members who they can call in times of emergency. Now, we know that if there's any critical incident in the home, it's time of panic, and sometimes you can no longer think of who to call. So it's best to always instruct them to prepare this list of contact na naka-post talaga sa visible part of their home, no, na it can be accessed right away in cases of emergency. So later on, you will see how perhaps you can do that, no, and instruct the families how to come up with a directory of their own as to who to call. Now, cornering in now on a very common physical concern and symptom in patients in our homes, and this is pain. Okay, and we have been seeing, of course, as Filipinos, no, matiisin tayo, no, and a lot of our patients actually may not even report the symptom outright, but it could be more of their family member who is seeing the facial expression, especially of our stroke patients who cannot express or verbalize pain. This is a common symptom, and it's a symptom that is considered something we need to monitor as the fifth vital sign even. So even in the home, this is something that we must instruct and guide our family members to look out for in their patients. So basically, we start with the assessment. No, it's not just giving biogesic kaagad. We have to teach them to determine the cause of the pain, and by getting the history and examining the patient, and we have to also explain that there are different kinds of pains. Um, Mainly, there is what we would call background pain, and it's the kind of pain that usually a patient would experience most of the time. So this is common, like for musculoskeletal pain, especially in the elderly. It could manifest as background pain, and that, like I said, sometimes it won't even be reported kasi parang nakasanayan na. It will be reported na lang if it increases in severity, or it's affecting the sleep already. So these are questions that also should be asked when assessing pain. And the other type of pain, which is here, is what we would call breakthrough pain, or pain that is triggered by something. It could be triggered by a certain movement, pain that even could be experienced after eating or by a certain position, or it could be spontaneous. But it is breakthrough pain that we would consider the need to put medications also. And this is what we call as rescue medication. So I'll discuss more of that later. So when assessing pain, be sure to differentiate. Is this pain that is being reported a background type of pain that they may need round-the-clock medications, or is it a breakthrough type wherein standby medication should be made available as well? Now, going on into assessment, we must check that if the patient who is suffering from this background pain and or breakthrough pain, how well is the control? Um, how what do they do in order to alleviate the pain, and is that enough? We also look into the psychological or spiritual components of this pain. Sometimes you can't even see a trigger that's outright like any physical trigger, but sometimes the trigger could be something emotional. uh, our our basic tension headache, is just an example of a, uh, a true source of pain, the muscles tensing up, but the cause of it could be something emotional or spiritual. So this is how we look into pain further. Are there other triggers, and are is there other a more deeper cause to the pain we're seeing? So this is very important to include in our assessment. Now, in grading the severity of pain, we would usually use a scale of 0 to 10. But then, of course, there are many ways to elicit, from 0 to 10. If the patient can verbalize, well and good, they can say, oh, usually when they say it's moderate, if they can't really grade it as a number, some would just prefer to say mild, moderate, severe, So our mild would be a score from 1 to 4. Um, and then 1 to 3, and then our moderate would be 4 to 6, and then severe type of pain would be scores from 7 and above up to 10. So for those, it's of course best to have that numerical scale so we can be it can be really monitored better. But then for children especially who cannot maybe really give that number or grade it, we can use a faces pain scale as well. So a certain facial expression will coincide with the level of pain. So that's also a scale we use, and I'll show you that scale in a bit. Okay, so this is the scale I was talking about. Um, and this is something we can use, especially the faces one, we use for either elderly or children who cannot verbalize. Okay, so you can teach the family members to actually grade this, even give them a copy of this scale. And then every time you would monitor or you would ask them to report to you, they would be it would be more objective in reporting. Now, for the treatment of pain, of course, most of our patients are experiencing more chronic pain. And there are some who may not even be able to take in medications already by mouth. So we have experience giving medications rectally, those that can be absorbed by the mucosal tissue. So we, we have been also using pain relievers. I remember going out in the community, we would still have, if there's really no other way, they don't have IV access, a rectal route is an alternative, but we have to guide them on the proper way of doing this. No, so painkillers should ideally for chronic pain, for background pain, like I said earlier, painkillers should be given at fixed time intervals. Ang sinasabi namin, kasi of course, a lot, we also could hear na, doktora, bakit iinom pa ba ako kahit wala na? But they would, think na baka it's not good to really be dependent on the pain relievers around the clock. But then again, we would have to see what is the cause of the pain. Is the cause of the pain something that cannot be reversed, especially if it's due to a large mass in the bones or a mass that is no longer responsive to treatment? So we can infer that the cause of the pain is continuous and even progressive. So this is the time where we have to educate them as to why it's important to get ahead of the pain by giving a regular pain medication at fixed time intervals. And then on top of that, we may need to even give rescue. So again, it's really going back to the underlying cause. Perhaps if the underlying cause is reversible, like maybe an inflamed knee, which may be just because of a lesion or infection that could be controlled by an antibiotic, but there's pain, we can we also advise that the pain reliever may not need to be continued after the cause of the pain is also resolved. So the medication should be tailor fitted to the individual. And we also try to make sure that the dosing does not affect the sleeping um, period time of the patient. So it should be during the day when they're awake. But if control is needed at bedtime, they could take a bedtime dose. Now, for the types of medications we use, the WHO analgesic ladder would be our main reference, and so it would depend on the severity of the pain, and this is where we would um, also combine the assessment of the cause, and then determine which medication would be best. So let me just go ahead and show our ladder. Now, the thing we'd like to just point out here is some pains can be start as step one and all of a sudden become severe. So you don't have to wait or go through the step two approach if you already are seeing a pain that has escalated right away to a severe type of pain. And so you can actually go up and down this ladder, but it just guides you as to what type of medication is best for mild pain, for moderate, and for severe, and that these medications can be combined with non-opioids. If you are already experiencing moderate pain or severe pain, you can give a weak or strong opioid and still combine it perhaps with an adjuvant, which is a non-opioid. So we have cases wherein, especially for bone pain, um, secondary to a sarcoma or bone sarcoma, you would see combinations like this happen, combining a strong opioid with an NSAID, and even sometimes a steroid. So this would just be our basic guide. And when we encounter this challenge of not having the medications available. This is something we're seeing right now, especially for opioids. But rest assured, we're also trying our best to make sure that our pharmacies and our providers make these available. But there are some medications that are over the counter, not requiring the doctor's prescription, we know, and that you can already start the patient on, given its proper use and checking for contraindication. So this is something that I think we also need to discuss in another time, wherein especially now that we are seeing the need for where actually they're accepting now our electronic prescriptions for some of the medications that are regulated, and we just need to get this information out, that where is it accessible, and what kind of medication can we start with in its absence. So for known palliative care patients, they have to be monitored, no, if they're taking pain medications regularly as prescribed. And we have to, again, empower them to monitor their pain and the effect of the medications that they are taking, especially those with cancer type pain, or cancer pain caused by cancer. Now, for those suffering from breakthrough pain, um, we, like I said, it's always best to have the medications on standby, and that they are instructed as to how to take them if they need a rescue dose. And they also need to be instructed not to wait for the pain to get to a score of 7 before they take the rescue dose. They should be advised that if they feel the pain is starting to increase, they should take the pain medications. We also should share with them that experiencing pain actually brings down also their ability to fight the illness, and drains them. It drains their energy, and they become more prone to other symptoms. So I think that's something important to share with our patients and those caring for them, so they will know the importance of getting ahead of their pain and controlling it promptly with the medications that we prescribe. Now, our role as health professionals in teaching the family and caregiver cannot be undermined. We or underemphasized. We really need to be there, not just to give them the first instructions, but to follow up and check on how they are doing in managing the pain of their loved one, and checking the frequency and just allowing them to understand the importance of giving medications regularly, like I said. And like I said, we're trying our best to make sure that our pharmacies in the community are well stocked with adequate pain medications, and we're working closely also with DDB and even PIDEA, and making this more available under, of course, our regulations to patients in the community setting. So now for COVID patients, we just wanted to highlight this, that um, for COVID-19 or suspected COVID-19 patients, the initial approach to them is not, of course, opiates immediately. We would see more of pain coming from the flu-like symptoms, which would be more common. So joint pains, body pains, in these types of patients who would be suspect or diagnosed for COVID-19. So the recommendation here would be more of round-the-clock NSAIDs. But if they're elderly and you want to lessen their intake, you can prescribe more of the once-a-day formulations of NSAIDs, such as celecoxib or eteracoxib. Now, for the same patients, of course, close monitoring and evaluation should be done remotely as often as possible. Now, if they still are not able to go to the hospital or don't want to go to the hospital, first of all, make sure that they are well instructed in terms of proper protective um, supplies, that they will use, the masks, at the same time adequate disinfection, but at the same time call them uh, regularly to see how their symptoms are. The follow-up being every 6 to 8 hours. Even if you did start a pain medication, you should check as promptly as after 6 to 8 hours, or even after 30 to 60 minutes, depending on the medication you prescribe. So we know that there are non-pharma interventions for pain. So again, another empowering of the family to use these, like warm compresses, warm sponge bath, even proper positioning. You can teach them that, especially for the elderly, and how to continue just providing encouragement and emotional support to the patient. And we also advise, even distraction through music. These are types of pain interventions that have seemed to also work, especially among our elderly. Um, they are more calmed when there's someone with them to talk to, or just something else to take their mind off the pain, such as music or simpleng balita. So these are, simple ways to also have control over that pain. So if a patient experiences, well, total pain, we call it, or existential pain, there's accompanying anger and a lot of questioning and frustration. Ano ba yung nangyayari? What's happening to me? Why at this time? Um, this is where we also need to empower the family to just listen, and even perhaps seek, spiritual care, which can also be done remotely. Maybe someone has to call to say a prayer for the patient, or just to listen and allow them to ask these questions. We may not be able to answer them ourselves, but just being there to listen to them already helps. And if we do feel that someone could help intervene, such as a counselor or a spiritual care provider, we encourage you to connect with them or connect the family with them. So, so this ends my segment. I will now pass over the time to Dr. June for the continuing part of this guidance. Dr. June?
Okay, hi ma'am. Okay,
Okay.
so
I'll
good
just click your.
afternoon everyone. Can you hear me po? Okay, so I'm tasked
Yes.
today to give out a short lecture on symptom management at home, as well as the preventive measures that could be done at home. So it is very important for us, palliative care advocates, palliative care provider, to educate and empower the families and carers to provide basic palliative care, particularly in the community setting. So we need to teach them on how to evaluate the signs and symptoms so that they could address it immediately. So the following are the key information to keep in mind in evaluating symptoms. First would be, is the symptom highly distressing and frightening for patients and caregivers? Meaning, are they capable of providing immediate care for the symptom or not? Is there a need to bring the patient to the hospital, or they could manage it at home? And the third one would be, is it highly responsive to non-pharmacologic and pharmacologic treatment? So those are the important things, information to keep in mind in evaluating the symptoms. So on the next slides, we'll show to us the general symptom management approach. And this means that the relatives, the carers, should determine and treat the underlying cause of the symptoms. They need to know, we need to teach them whether it's physical in origin or non-physical, whether it's a whether it's a psychosocial issue or not. So after assessing whether it's a physical origin, they need to treat the symptoms without causing new symptoms or side effects. So it's very important for them also to know the side effects of the medications, because they also need to weigh the risks and benefits of every procedure, whether it's non-pharmacological or pharmacological. And of course, we need to take into consideration the best interest of the patient, and that is alleviation of suffering and providing comfort. Okay, so for the next slide, what can we ask from the families? We also need to take into consideration the use of technology through Viber or through phones for updates, kagaya ng ginagawa ng the Root Foundation and us in Active Care, and including PGH. They do teleconsultation as well. So what can we ask from the families? We need to ask or review the timing of onset, whether it's after meals, before meals, or upon movement. So you need to ask that too. And also symptom characteristics. They need to adequately describe the symptom. For example, if it's pain, is it crushing? Is it lancinating? Or is it parang mahapde? So you need to ask that as well. Also, associated symptoms are important. So for example, if the patient has difficulty in breathing, is there a concomitant chest pain, dizziness, headache, or loss of consciousness? So that's important too. And also, palliating and relieving factors and aggravating factors such as movement, such as deep breathing, or upon eating are important questions to ask from the families and carers. And the impact on functional status should also be asked. For example, because of the difficulty of breathing, the patient is unable to eat. Because of the difficulty of breathing, she's fearing that she is dying. So it should be asked from the families as well. And one of the most important things to ask would be response to the medications that are being given to our patients. Let's say after giving one dose of morphine, is the symptom relieved by 50% ba, 100%, or not relieved at all? Because these questions will actually guide us on further managing the patient. Okay, so for the next slide, here, I'll be discussing the common symptoms that could be managed at home or in the isolation units. So the most common symptom, respiratory symptom, is difficulty of breathing or dyspnea. So here, very important to assess whether it's physical or non-physical. So for if it's physical, primarily it could be due to the progression of the illness. It could be due to an infection or tightening of the airways. So for the basic home management, you could instruct the patient to have a tripod position, heads up, leaning forward, and also you could consider deep breathing exercising. And it's quite effective if we do breathing exercises together with the patient. Breathe through the nose slowly and breathe out through the mouth slowly. Also, opening the windows to allow air to come in is beneficial for some patients. And cooling the face with a cool cloth is effective as well. So with the advent of technologies, meron ng mga uh, handheld electric fans, mga USB fans. So it could be used to relieve some sort of dyspnea from our patients. And if it's non-physical, if the cause of the dyspnea is non-physical, like anxiety, we also need to provide assurance and counsel the patient. And apart from that, we need to identify situational components. For example, if the trigger is emotional, for example, may nakausap siyang kaaway niya or may napanood siya sa TV, you need to identify the trigger to address it promptly. And also, we could teach behavioral interventions to our patients, lifestyle modification, mindfulness, refocusing. Those are some of the behavioral interventions that we could teach to our patients. Okay. So for the next respiratory symptom, which is cough, so we need to again assess the cause of the cough. Is it a productive cough or is it a dry cough? So for basic home management, you could allow the patient to sit up and reposition the patient in sitting up position. Also, you could humidify the air with steam, especially if there are no nebulizing medications that were prescribed to the patient. But if you have a patient with prescription, you need to empower the relatives on when to start the nebulization. And after each nebulization, physiotherapy is also advised, particularly for those patients with productive cough, para ma-loosen up yung secretions, para mas mailabas nila, ma-expectorate nila yung kanilang phlegm. And for those patients with existing prescriptions for cough, let's say kung dry cough, we have cough suppressants like levopron or you have dextromethorphan, you could reinforce to them when to give it. And for patients who have a productive cough, of course, you need to empower them to give the appropriate medications. And another important note would be to identify triggers for the cough. Let's say if it's allergic cough, if there's someone smoking in the area, then you need to advise the relatives to stop smoking. Also take note of the modes of cooking for the family. Let's say if they're using charcoal, if they're using wood to cook for their food, then advise to find a way to shift to another form of cooking. Okay. So for the next common symptom, we have the GI symptoms like nausea and vomiting. Again, just like with the other signs and symptoms, we need to identify whether the cause is physical or non-physical or related to the emotional aspect of the symptom. So for nausea and vomiting, you could give small frequent feeding to your patients para hindi sila mag-bloat kasi if they would eat lots of food, kunwari mabibigla, they will feel bloated and that will trigger nausea and subsequently vomiting. And some patients would actually benefit from ice chips para mawala yung sense of nausea nila tsaka yung vomiting. Also, take note whether the nausea and vomiting is a result of a drug or a side effect of a drug because some of the medications could actually bring about nausea and vomiting, just like with opioids initially, etc. Also, taking drinks slowly and more frequently could alleviate the sense of bloatedness, which will prevent nausea and vomiting. So if the patient, let's say, is vomiting and is unable to sit up, you need to turn them to the side to avoid aspiration. Because if they aspirate their vomitus, magkakaroon tayo ng aspiration pneumonia and andun na yung cascade of suffering like fever and eventually pwedeng mag-expire yung patient because of that. Okay, so for the next slide, the next GI symptom, we have constipation. So constipation is among the more common signs and symptoms for our bedridden patients, primarily because they are bedbound, hindi sila makagalaw, hindi sila nagmo-move. Of course, kapag di ka nagmo-move, your peristalsis will not move that well too. Okay? And also, you need to identify whether the constipation is caused by a drug, like opioids. So in opioid-induced constipation, rule of thumb, we need to provide laxatives. So we need to, again, remind the family members to give laxatives for those patients who are suffering from opioid-induced constipation. And we could also offer drinks often. We need to hydrate because dehydration could also give constipation to our patients, giving frequent drinking of water, prune juice could be given to alleviate the dehydration and eventually could address the constipation. But for some patients who are cancer patients, let's say, giving fiber is not recommended kasi we might push the patient to go on obstipation or pwedeng magkaroon pa ng fecal impaction because of the increase in fiber intake. Kasi nga, poor oral intake, poor water intake, hindi makamove, yun yung nagiging cause ng fecal impaction. Also, abdominal massage on top of the laxative treatment could be beneficial for some patient. Sometimes it's therapeutic na hinahawakan sila. Di ba sabi pa nga ng elderly natin, di ba yung pag-a-apply ng sebo de macho could ease the abdominal discomfort. And also, we could apply warm compress on the abdominal area to relieve constipation as well. And for some patients who are not responsive to laxatives, let's say, and na-rule out na yung rectal mass, we could do rectal stimulation. But for some patients, it's very discomforting. So there might be a need to give pre-procedural pain control. If the patient was prescribed with opioids or pain medications before, maybe you could give it 15 to 30 minutes before the manual evacuation para meron tayong coverage for pain. Kasi nga, di ba, as palliative care providers, palliative care advocates, we would want to alleviate the suffering of the patient, and we would not want to add more suffering to them. Okay, so for the next slide, we have the general body symptoms like anorexia, weight loss, weakness, and fatigue. And it is very important to educate the family whether the cause of the symptoms are reversible or not. For example, if the anorexia is due to cancer, then we need to educate them that no matter how much we feed the patient, anorexia and cachexia would still persist, especially in the latter part of the illness trajectory. Okay? So, at home, we could ask the patient kung ano yung gusto nilang food. We need to explore kung ano ba yung cravings nila. Sometimes it will trigger their appetite because of that. And we could offer smaller meals or soft food para mas madali nilang maswallow. We could give milk formulas as prescribed by their doctors or their healthcare provider. And sometimes bini-blenderize yung food, yung viand, yung ulam, tsaka yung rice with water para mas madali nilang maswallow. And we could also offer frequent sips of water, but we would not want to force them to drink water kasi baka magkaroon tayo ng risk for aspiration. So magiging beneficial din dito yung ice chips, yung energy drink na finreeze natin to serve as ice chips. Makakatulong din yan for them. And also, we need to educate the family to learn to accept that oral intake will be reduced as the condition progresses, particularly for cancer patients, for geriatric patients na medyo elderly na talaga, for demented patients, for patients who has Alzheimer's. And also, we need to ensure daily oral hygiene. We need to physically check or empower the carers and the relatives to check the oral cavity, to check for sores, to check for lesions, to check for candidiasis, kasi it might add to the anorexia of the patient. So we need to address it promptly. Okay, so for the next slide, it will show to us the psychological and emotional symptoms like confusion, delirium, and restlessness. So ito yung ilan sa mga distressing for the family. Yung restlessness, delirium, lalo na if they're nearing death. So we need to educate again the family members the process of dying, let's say, if they have a dying patient. Now, it's part of the process. We need to also address it with medications. So again, empower them to give appropriate medications during the end of life phase. But for some patients who are not yet dying, just provide a familiar environment and also remove dangerous objects. Of course, if they are restless, if they are in a delirious state, pag meron diyang matalas na gamit, it will pose more harm to them and even the family members. So remove those objects and reassure the patient. Hindi nyo i-challenge yung kanilang thoughts. Kundi reassure them, you would use simple words, simple sentences para ma-address yung kanilang confusion and restlessness. And very important to explore the uncontrolled hidden pain because bed sores, urinary retention, and constipation are culprits for confusion and delirium. So empower the relatives to check to do physical examination, palpate the abdomen, palpate the hypogastric area if there's urinary retention, or take note of the number of days na walang bowel movement yung patient para mabigyan natin ng medications na mag-relieve ng symptoms na yun. And eventually, ma-relieve din yung confusion, delirium, and yung restlessness. Okay? And for the next slide, this part naman, yung preventive interventions at home. So, sobrang basic lang nito. The first one would be preventive oral care. So again, the very important would be to do regular physical exam. Do regular physical check of the oral cavity. Look for lesions, look for changes in the color of the tongue, and including yung throat. So if your patient is able to brush his teeth, pwede kang gumamit ng soft bristled toothbrush and with toothpaste. Pero for your patients who are unable to take care of their oral health on their own, just advise them to gargle with leftover antiseptics, oral antiseptics like povidone iodine 1% solution, 2 to 3 per day after meals. But for those patients who are not able to afford those over-the-counter medications, care. But for those patients na hindi na talaga rin makagargle, so we need to address friction. So empower the relatives to look for skin changes. Kung may namumula, you need to educate them that this might be the first signs of bed sore. So you need to empower them to change the positions frequently from 1 to 2 hours for those totally bed-bound patients. Use pillows on the bony prominences like the legs, in between the knees, in between the ankles, and also check for the bony prominences to keep the skin dry and clean, especially the clothes and the beddings. Kasi alam naman natin na moist, damp areas are culture media for bacteria. And of course, exercises. For those totally bed-bound patients, we need to do passive range of motion exercises to prevent contractures and to prevent bed sores then. We could also use egg crate mattresses and pneumatic air mattresses to at least relieve the pressure from the body of the patient. And then the next slide would show to us the basic preventive intervention of bathing. So this could be full bed bath, pwedeng tepid sponge bath lang or half bath. And very important, again, would be to do comprehensive physical examination. And this is the perfect time to check the totality of the patient from head to toe. Especially kung yung patient mo is able to move pa, you could allow him to bathe in the bathroom, just put a monoblock chair there and assist them with bathing. And even with patients who are in vegetative state, it's very important to provide privacy during bathing kasi we would want to maintain the dignity of the patient. Also, do not rush the bathing process. Ito yung time na kailangan natin i-check yung kasingit-singitan ng ating patient para ma-prevent natin yung bed sores, ma-prevent din yung other signs of infections. Since most of our patients are immunocompromised, minsan sa flabs ng kanilang skin under the breast, sa groin area nila, pwedeng may nagsistart na fungal infection. So we need to check that as well. And use warm water. Do not use cold water kasi baka magulat sila, or hindi rin pwedeng hot water kasi most of our patients, yung skin nila ay fragile na. Pwede silang ma-burn easily. And also, we need to keep the beddings dry, especially for those patients na we're doing bed baths. So we need to use plastic sheets under the skin or the bed para hindi mababasa yung beddings nila. And for those patients na merong pre-existing pain conditions, let's say bone cancer, fractures, we need to give pain medications prior to bathing para meron tayong coverage for incidental pain. So usually the doctors would prescribe opioids or other medications 15 minutes or 30 minutes before bathing the patient. So that's very important. And The next one, actually the last preventive intervention, would be the prevention of pain, stiffness, and contractures in muscles and joints. So again, this is very important para makita natin if meron ng signs of early contractures, very difficult to manage contractures kapag napabayaan na yan. So again, physical examination is important. And for those patients who are able to mobilize, even with assistance, encourage them to move. Assist them kahit simpleng bed, transferring from bed to wheelchair or to chair. Encourage them to move to tolerate it na. And of course, pain medications in every movement, let's say, dapat tayong magbigay ng pre-procedural pain control. And for some patient, light massage, lymphatic massage, nakakatulong to sa kanila emotionally and physically din, especially for some patients na merong mild edema, makaka-alleviate din yan ng pain from edema. So I guess that's my last slide.
Yes.
Yes, so I'll just give the floor to Dr. Agnes Bausa, who would tackle care in the communities. Thank you.
Okay, thank you, Dr. June. Thank you for going through those list of symptoms in just how many minutes. Now, normally, as I turn over the time to Dr. Bausa, normally that would take a whole afternoon to go through each of those symptoms, but Dr. June did it very well, just to going through the key points for our community care providers. So, Dr. Bausa,
All right. So my topic is about care in the community and a little about end of life care and bereavement care. So can we go? Can I press the for the next slide?
I'll be pressing for you.
Okay, just to set the expectations of the group, we are talking about palliative and hospice care. And we have to be strict with the principles of palliative and hospice care, and which are the following. So we do not hasten or delay death. We do not give anything to hasten the death of the patient. And we also do not delay the death of the patient. So like doing intubation and resuscitation delays the death of the patient and prolonging the suffering of the patient. So we have to remember that and recognize that those patients who are progressively deteriorating and death is part of our life. It's a normal process of life, and we focus on comfort and not on cure. And of course, improving quality of life, not just of the patient, but also of the family. And we offer other support services. No? So these are the three. Okay, for the next slide.
Nestle? Oo. Ay, okay.
Okay, so we allow the patient to continue to experience being treated. And these are the three main focus of palliative and hospice care is for us to do management of distressing symptoms, and of course, discussion of wishes and expectations via advanced care planning, and of course, articulation of goals of care and supporting the patient and the family with this life-threatening condition. So once the advanced directives is established, then the plan of care should be discussed with the patient and the family. Next slide, May. Okay. So in the care in the community, of course, we have the rural health units, barangay health stations, and primary care facilities, health centers. We have to find out what is available locally. Of course, it's if we talk about palliative care, not all communities have palliative care services, and even NGOs or community-based services. So is there a doctor who can visit the patient at home? Can we arrange community nurses and provide nursing care? And are there palliative care specialists in the community that we can refer, or even palliative trained nurses, and other specialists like cardiologists, pulmonologists, and other psychologists, that we can refer the patient. Okay, are there groups providing psychosocial and spiritual support? We know there are also doctors who are offering bereavement care, psychosocial support through telemedicine. Next slide. Okay, so these are the things we have to keep in mind, no, when we are in the community. So what are the stuff, no? What are the essential medications in the end of life care, and even for not just for end of life care, but for distressing symptoms like for pain, for dyspnea, for restlessness, agitation, secretion. So these are the morphine, midazolam, and hyoscine and butyl bromide, no? Most commonly used in palliative care. And also, there was a special regulation for psychotropic drugs amended this May 14, no, yesterday, that electronic prescriptions for regulated medicines can be used uh, until the ECQ or GCQ is lifted. So we can still continue our electronic prescriptions even with the use of morphine. No? So what are the equipments that are needed in the rural health units or in the community? No? Depending on the patient's needs, are there suction machines, oxygen, syringe pumps? No? This, I think, may be a problem, no? Because these equipments are not commonly present in the community, especially the syringe pumps and the equipments for IV drips, no? And the staff, no? It is recommended that we have to mobilize clinicians who have palliative care experience. So I think I will go to that later on, how we can make this possible, no? And even nurses with palliative care experience or training, no? So we, in the community right now, we have to provide brief education for frontline providers or healthcare workers for symptom management, which we are doing now, and engage other allied health professionals. Okay, so for the space in the community, and I think there are spaces that are provided for patients who are isolated for a probable COVID infection. But if for mild symptoms, they are not hospitalized, they are isolated, or even they are at home. And for non-COVID patients with symptoms, this is a common problem because they are labeled as a probable patient, no? And sometimes, if they're brought in the hospital, they still go through a lot of process, no? They are swabbed and they are, there's a stigma, no? Along with having a symptom of dyspnea, even if it's related to the progressive disease, no? So another important thing is the system. So we have to adapt a triage system that required palliative care consultation, which soon we will be doing, and maximize the use of telemedicine. But in a while, I'm going to suggest this ECHO model, which was used in Mexico and published in 2013. Wherein a lot of third world countries using right now, like India, they have 25 Eco Hub. What else? Indonesia, Bhutan, Sri Lanka, Malaysia. So we can also adapt this. And another important thing, no, in the community is communication. Communicate with patient, with family, and the staff. Everybody should be on the same page. Everyone should know what is the plan of care so that everyone will have the same direction in the management of the patient. And of course, equity. It's a common question now, especially this pandemic, no? For those, equity should be the same treatment and management, even for those poor patients and marginalized patients. Next slide, May. Okay. So in the community, I will not be discussing this in detail because this has already been mentioned. But I think what is important in this slide is for the doctors, the community doctors, and the community nurses and healthcare workers to be able to assess properly the patient, to be able to give the proper and appropriate advice, and communicate it with the patient and the family, and agree with the plan of care, and assist them in the medications, assist them in the procurement of equipments that is needed at home, and to be able to arrange transfer or transport of patient whenever necessary. Next slide. Okay, so these things, no, prevention of bed sores, contractures, bathing, and everything that was earlier discussed should be provided by the healthcare workers, the nurses and the doctors who is visiting the patient at home. Next slide. Okay, teach morphine, oral morphine to the patient and the family. Okay, and give instructions how to adjust the dosage, no, depending on the report of the patient. Next slide. Okay, so next slide. Okay, so this is the latest advisory of Dangerous Drug Board's amendment of the advisory dated March 18, 2020. The use of electronic prescription for dangerous drugs during the duration of the state of calamity pursuant to Proclamation 929. Previously, it was stated here that the use of electronic prescription is until September. But now, it was stated that throughout public health emergency. Okay, so until hindi nalilift ang ECQ and GCQ and still in public health emergency, we can still use the electronic prescription. Next slide. Okay, so this is an example of an electronic prescription for regulated medicines, no? So it should contain the same information that is in the yellow prescription, and it should contain the name of patient, the address, the age, the sex, the dose, no, the name, the generic, and the brand, the instructions how to take, and you should put no refill, and it should contain the words page 1 of 3 pages, page 2 of 3, and page 3 of 3. So, dapat tatlo ang ipapadala ninyo pag nagbigay kayo ng electronic prescription for regulated medicines. Next slide. Now, this is what I said earlier, the Project ECHO. ECHO means Extension for Community Healthcare Outcomes. No? So, next slide. So basically, the Project ECHO allows primary care physicians and other clinicians to have the ability to learn, to provide excellent specialty care directly to their patients in their own practice. So this tele-ECHO, no, there's a virtual grand rounds, and the clinicians are from multiple locations, and they regularly meet on a scheduled time, and they consult a multidisciplinary team through video conferencing. And most commonly that is used now is the Zoom meeting, which we are doing right now. So next slide. Okay, so people in the community can access advice from specialists, no? Primary care physicians or clinicians can give excellent care to the community, to the patients in the community, by consulting this multidisciplinary team. No? So this can be done to places like the rural and underserved communities. Okay, so the difference of this project, the ECHO method, is that from telemedicine is that in telemedicine, the one answering the phone, the doctor answering the phone, assumes the responsibility of the patient, while in tele-ECHO, they do tele-mentoring, no? And the physicians, the primary physicians, retain responsibility in managing the care of the patient. So we just provide the advice through discussion of the case of the patient, and physicians, nurses, and community healthcare workers can still continue to manage the patient, wherein they're the best people who knows the patient well. No? So next slide. Okay, so this eco model, they're saying that you move the knowledge to the people. You transfer the knowledge to people, and not people going to the community, but instead transferring the knowledge to the people in the community through knowledge exchange. No? So once the knowledge is transferred, they're able to manage the patient in the community with confidence. Next slide. Okay, so when we see patients in the community, we should always keep in mind the values, the belief system, no, of these families, no, and these behaviors, belief, traditions, they influence, no, the decision making and the action of patients in the community, and it also has an effect on the way they react to their situation, and in terms of grief and bereavement, no? In the reaction. Next slide. Okay, so we also have to assess spiritual history of the patient. No, the most commonly used to assess spiritual history of the patient is the FICA. No, the FICA, which means F for faith and belief. You assess the faith and belief. You explore it. I, for the importance of spirituality of the in patient's life, no? And C, is there a community that supports the patient and the family? And A is assessment, no? How do you want us, the healthcare, address your care in the future, especially towards the end of life? So the spirit is just the same, no? It explores both faith, belief, importance, spiritual community, and how you want to be addressed, no? In the future for your health. Next slide. Okay, so grief and bereavement is a difficult topic. So it's a long discussion, but I will just give a very brief talk about this grief and bereavement. So bereavement is the state of loss, no? Resulting from the death of a loved one. So ang sabi dito, no, there are 4 phases that a person should undergo to be able to move on with her life. So they have to experience the pain of having loss of a loved one, fear, anger, and resentment. They have to feel apathy, aimlessly, and sadness. But most importantly, to be able to have hope, no, and move in a new direction. Next slide. Okay. So grief is an emotional response, no, that is associated with the loss. So it occurs after the loss of a loved one, no? So next slide. So it's individualized, no? Ang response to grief is different from one person to another. While mourning is the adaptation to the loss of a loved one, no? Including cultural and rituals, no, should be done in order to move on. So example of this is wearing black clothes, no, and other rituals that we do. No? Next slide. Okay. So to be able to move on, no, a bereaved family should be able to accomplish the following: accept the reality of loss, experience pain, adjust to a new environment, and the most important is to withdraw emotional energy from the deceased and invest in new relationship sa mga taong buhay at hindi sa namatay na. Next slide. Okay. So it's difficult for family members, no? Yung bereaved, sila yung family members, sila yung nawalan. It's difficult for them because of the feeling that they have been robbed of someone that is very important to them, no? And it was forcibly taken away from them. So at this time of pandemic, no, ang dami nating mga kakilala, no, na nawalan ng kapamilya, and it was very untimely. So they feel that at this time of pandemic, namatay yung family members, so they were robbed of this very important person. So nawala sa kanila ng bigla without any preparation. Next slide. Okay, so the bereavement doesn't start when the patient dies. It actually starts from the time there was disclosure of a life-threatening condition. So it starts when the news of cancer was given, or the news of recurrent was given, or there was a disclosure of end-of-life care, or pag sinabihan na malapit na ang buhay. So bereavement starts, no? It is not at the time of death of the patient, no? And both patient and the family members experience anticipated grief. Next slide. Okay, so what is anticipated grief? Anticipated grief for the patient is contemplating, no? Already, the patient's already discerning regarding the separation of himself from the loved one. So that is anticipated grief. And the loss of the future, the loss of the dreams, no? So all of this are internalized in anticipated grief of the patient. While the anticipated grief of the family is the family is already internalizing, already coping for the eventual death of the patient. No? While reactionary grief is only for the family members. Kasi pag namatay na ang patient, doon na papasok yung reactionary grief. No? The family's reaction or coping to the death of the loved one. Okay, next slide. Okay, so for us, for each family, for each patient, there's different meaning of death, no, for each one of us. Like, we are all afraid to die, okay, because of this COVID infection. So we are afraid that we will lose our life, untimely loss of our life without any preparation, okay? So we also don't know, no, if for some people, no, they may think, no, na what happens after death, no, there might be no place for them, no, maybe there's no afterlife. That might be their belief, no. We will not be able to enjoy anymore our daily leisures, no? We have no more time to talk to our loved ones, to ask forgiveness, no? No more time to laugh with them, okay? So with being a doctor, we also have this fear that sayang tong mga knowledge natin, no? Kung tayo mamatay, hindi natin ma-transfer to our colleagues, to others who needs it. So there are different meaning of death to us, no, and different fears, no, of these losses. Next slide. Okay, so however, these losses may not be the same. The impact of these losses may not be the same to each one of us, no. Some may be able to cope immediately. Some may be wounded for so many months or years, no? And some may be able to go on, but mahihirapan mag-cope up, no? So dealing with losses will take time, no? So that's why we have to understand the patient, the family, and explore their grief, their belief, no, and their coping mechanism and their support system and any resources or source of support in the community. Next slide. Okay, so working through the losses takes a lot of effort, no, for all of us. We have to sit down with the patient, no, we cannot force them to talk, we just wait for them to ventilate, no, and it's good to have training also in terms of active listening skills or communication skills to be able to get the needed information and explore the belief and what is inside the patient and what's going on, and be able to make necessary um, changes or counseling or advice, no, for the patient to be able to, for the family particularly, to be able to move on without the patient. Next slide. Okay, so as regarding referral network, no, we really want palliative care to be part of the service delivery network of the Department of Health, no, and though it's already integrated in the universal health care and integrated cancer bill, we are still in the process of organizing and creating policies and guidelines and referral networks. No? So I end my talk. Thank you for listening.
Okay, thank you, Dr. Agnes. Okay, so so that is the last part of our talk for guidance in the community. We actually are giving access. You can have access to these guidance papers in the Facebook pages, no, of the Philippine Society of Public Health Physicians, the Facebook page of Hospice Philippines, and even the Facebook page of the Ruth Foundation and the Society of Palliative Medicine as well. So just visit our pages, and you will also see that in the latter part of this first guidance document, as we also want to um, collaborate and partner with you, providers in the community, in uh, the latter part of our first guidance paper, you will see a table there wherein we are encouraging managers of health in the community, heads of clinic, those who are providing care to the grassroots, to create this table, or to fill up this table wherein you can create, which will reflect your referral network. So this is something we wanted to emphasize also as we share this guidance paper, that we need to empower not just ourselves as providers, as programs, but also our patients, and linking them with a referral network. So we have to have our own directory and table that will guide us and help us guide our patients as well. So as we close, we would also like to answer a few questions. We have uh, like maybe 5 to 10 minutes. I understand that there is a question regarding caregiver fatigue early on, and how do we detect, or what would be a way to detect caregiver fatigue among our families. And actually, Dr. K, one of the contributors to these papers, actually shared her answer. A practical way is to actually just converse with them, and see, and just listen to them in their level as to how they are coping. And then another clue is how the patient is actually doing, because it will reflect also if the caregiver is tired or already burned out, the quality of care is affected. So objectively, you can also measure burnout by the actual status of the patient they're caring for. And at the same time, just taking time to converse with them and allowing them to express their difficulties, you can measure. But there's actually a validated tool that you might also want to look up. It's called the Modified Caregiver Strain Index. Dr. Ake shared this, and there's also a Filipino version. So again, you might want to look this up, the Modified Caregiver Strain Index. So thank you, Dr. Ake, for helping us answer that question. Now, there's also a question about the symptom of dyspnea, especially during this time of COVID. So for patients, the question is for patients with dyspnea, one of the symptoms of COVID-19 who have no advanced care plan yet, do we advise them to be swabbed immediately? I think I will ask, is Dr. June still there with us? Dr. June is actually also one of our doctors based in a DOH hospital accepting COVID patients. I can ask him to answer for us.
Oh, yes, ma'am. Can you please repeat your question? I did not catch that.
Sorry. For patients with dyspnea, which is one of the symptoms of COVID-19 who have no advanced care plan yet, do we advise them to be swabbed RT-PCR immediately?
Actually, for patients who are suffering with dyspnea and are symptomatic, especially immunocompromised patients, I guess majority of the DOH hospitals would require swabbing and tagging the patient as a suspect or as a probable case, and then the patient will eventually be isolated. Then after the isolation process, they'll wait for the result of the swab, whether it's negative or positive. If it turned out to be negative, the patient would be transferred to a regular ward or in a regular private room. So I guess with the condition of the patient, severity of the symptoms, and the immunocompromised status of the patient, and most of us here are living in a locality wherein there are lots of cases, then it's prudent to test the patient for COVID RT with a PCR.
Okay, thank you, Dr. June. Of course, along with that, we just talked about advanced care planning yesterday. I spoke with a group of patient advocates, and this is definitely something we need to echo to the community as well. The importance of advanced care planning in even before any symptoms of illness occur. So this should be made available, this type of counseling should be made available to the public as well. So we have time for a few more questions. Dr. Lester, I think the next one about, do you know if DOH has any plans to require hospice care in all level 2 and 3 hospitals? Dr. Abausa, maybe you can answer this. Do you know if DOH has any plans to require hospice care in all level 2 and 3 hospitals?
Yes, yes. DOH right now is developing the manual of operation, no, and developing palliative care modules, no, to be implemented to primary care, secondary and tertiary levels, no. So level 1, level 2, level 3, and even the tertiary hospitals. So lahat i-cover ng Department of Health. So we are now in the process of doing the manual of operations for all levels. So just wait for it, and it will be implemented, and it will be cascaded to all the levels of care.
Okay, and thank you, Dr. Bausa. Yes, we will look forward to that. And we have just one more question before we close. Are there any national groups or regional support groups for caregivers of the chronically ill patients? Would anyone like to share if they have any knowledge of, this is a support group not for patients, but for caregivers? So anyone from the society, if they are familiar, actually right now, I have no knowledge of any, but we believe that it's very important. You might want to look up the Facebook page of the Philippine Alliance of Patients. the Advocates for Patients, PAPO. They may have information regarding that, but we will look up this. We'll check it out if there are any. We know maybe perhaps for specific disease-specific support groups, there may be, like for certain kinds of cancers, especially childhood cancers, there may be like support groups for families or for their parents. But we will look into this and maybe try best to post this, no, in our Facebook pages as well. Okay, so it's almost 7 o'clock, and we thank you for bearing with us for the last 2 hours. We know it's a lot to absorb. All of the information from background to basics to all of those symptoms, we just kind of went overview, and now even going into grief and bereavement. I know these are quite heavy, but we appreciate that all of you are interested and really want to be informed and enabled to understand in order to provide initial care and understanding to the patients in the community. And this is something we really value, just coming together this evening. And of course, this is not the last. So we hope you will continue to tune in to the announcements of our next webinars. And this is also provisional. No? We would like to also share that this is still, again, a work in progress. And we are also constantly reviewing these guidance documents. And we hope to provide updated versions soon.